Right. Good morning, everybody, or good afternoon, rather. Thank you ever so much for inviting myself and Gemma to speak to you today. I must admit I'm more nervous than normal, having seen the company that I'm sharing on stage this morning, what with Professors Cynthia Formosa, Armstrong, Bolton. I'm following Lee Rogers, so it's quite a tall order for me, but I'll do the best I can. We've been asked to talk to you about the monofilament. Obviously, it's been mentioned in previous talks about neuropathy, or the loss of sensation, protective sensation, and a monofilament has become very important in diabetic foot screening as well as diabetic foot examination. Now, obviously, repeating things, peripheral neuropathy is a loss of sensation in the foot. This patient came to us a little while ago. You'll notice that he's got a few ulcers. It's relatively unusual to see a purely neuropathic wound these days. Most of them tend to be neuroischemic. Essentially, what happened with this chap was he decided that he's a diabetes patient. He decided he needed to lose weight, so he bought himself a new pair of trainers and went for a very long walk to try and lose weight. Unfortunately, he'd forgotten the fact that he had lost protective sensation. And reiterating Dr. Paul Brand's contribution to diabetes, he's the guy who sort of coined this phrase, the gift of pain. Now, if any of us who have normal sensation would walk for a distance and you get a little stone in the shoe, then you will stop because you can feel it, and you'll take your shoe off and you'll remove the stone. With patients like this, they don't realize what damage they're doing because they cannot feel it. They've lost the gift of pain, as Dr. Paul Brand would say. So it's up to us to inform them if they do have any loss of sensation, and the commonly regarded examination now is using the monofilament. This is the monofilament. This is something that the company I work with made a very long time ago. It says back in 1995, 96, and what it was impressed upon us as designers and manufacturers was that they wanted a reliable and accurate monofilament, because if the patient did have a loss of protective sensation, then we needed to ensure that this was an accurate diagnosis. As a British person, I'm delighted to say this is actually designed and is still manufactured in the UK. And it's popular all over the place. We'll see it all throughout the world. And in fact, Professor Andrew Bolton, who will be speaking to you a little bit later on, helped us with the development of this, because he wants worldwide care of diabetic foot. And up until the monofilament was established, a lot of people were using biothesiometers, neurothesiometers, etc., which required a battery source or an electrical source. So to have something like this, you can use it throughout the world. So it was quite a step forward for us. Why use it? I think Dr. Rogers has just impressed upon us the importance of testing for loss of protective sensation. Obviously, if the patient comes into you, they already have a wound, there is no need for a monofilament test. Once the patient has ulcerated or had an amputation, they are forever high risk anyway. The monofilament comes in handy when we are looking at the low risk or the at-risk groups. So if they're at low risk, they're a diabetes patient, yes, but they have good sensation, they have good vascular sufficiency, they don't have any foot deformities or significant callus. So what the monofilament does is we will test for loss of protective sensation. And this is recognized as good practice by the groups on the slide. In UK, we have NICE, as it says on the bottom of the screen there, and in the NICE guidelines for diabetic foot care throughout UK, the only tool that is recommended is the monofilament. Everything else is history taking and pulse. So this is the only tool that is sort of recommended by the UK NICE group. The history of the monofilament, Dr. Rogers touched on this. It actually went back to horse hairs a long time ago, and the thicker the horse hair, the more pressure was exerted by that particular hair. This was sort of refined back mainly using patients suffering with Hansen's disease or leprosy, where neuropathy is significant as well. And this is where Dr. Paul Brand, again, he's a bit of a hero of mine. He contributed a heck of a lot to that field and brought his knowledge and his experience into the diabetic foot world, for which we should all be grateful. So there was a lot of monofilaments around. There didn't seem to be any sort of standard, but as time moved on, more and more work was done with it. And essentially what we needed to do was to establish at what level does a loss of protective sensation mean that the patient's going to develop a foot ulcer. So there was a lot of work done, such as Kumar, but it was back in '92 with Najarian and later on with McGill, who basically looked at a prospective study. So they looked at whole groups of works, and they decided that the level at which 10 grams indicated a loss of protective sensation, that's where it was done. So if you wanted to read more about this, there's a very neat little article called A Perfect 10 by Dr. Matthew Young. Dr. Matthew Young is a physician up in the Royal Edinburgh Infirmary, but he also is the editor of the Diabetic Foot Journal. And what I would advise you to do, if you do have an interest in a diabetic foot, then if you search on your sort of Google searches or something, if you put diabetes on the net UK, then you can gain access as healthcare professionals to the Diabetic Foot Journal. Not only is it to the current journal, but it will give you the archive, which goes back, I think, around about 21, 22 years. So if you're doing any searches and you want to read articles, then Diabetes on the Net is an extremely valuable asset for you. So the retractable monofilament, we were asked to make it retractable because a lot of the current monofilaments had special little cases. The monofilaments were exposed, and because they were exposed, they were put into clinicians' pockets, taken out again, they were bent, they were snapped, they went all wrinkly, etc. So we launched ours, which could be withdrawn into the plastic body and therefore protected. This was launched at the Malvern Diabetic Foot Conference. The image you see is the location. This is in the middle of the countryside in England. The hotel is there right next door to the Abbey. This is called the Abbey Hotel. The Malvern Diabetic Foot runs every 2 years. It was cancelled last year, thanks to COVID, but it was run again last week, and it will be running again next year. So two of the founders of the conference are Professor Andrew Bolton and Dr. Andrew Connor, who's sadly no longer with us. But they wanted something that was repeatable, something that was accurate, and something that could be protected as well. So this is where we came along. The main issue was the material being used. Now, nylon monofilaments have been used for several decades. So to ensure accuracy, we looked at the best material to make a monofilament out of. And nylon is okay, but the trouble is it absorbs atmospheric moisture. So at different times of the day, it will alter the modulus of elasticity within the monofilament. So for example, if any of you have a washing line at home made of nylon, if you in bright sunshine, which we're experiencing in the UK at the moment, that washing line will be very, very taut, it will be tight. But if you suddenly have a lot of rain, that nylon washing line will absorb the moisture and it'll droop. And that's exactly what was happening with monofilaments. So we purchased a testing machine, which I'll talk to you about in a few moments. We tested every monofilament we could find. And what we found with the nylon monofilaments was that the variation within a single monofilament could be as much as 10 grams. And 10 grams is what we're looking for at the point of saying that the patient has lost their protective sensation. So this means you'll end up with false negatives and false positives. So your monofilament, your nylon monofilament may be bending at 5 grams, you think everything is okay, whereas the patient could be suffering from loss of protective sensation. So we needed to make sure that we got a more accurate and reliable material. So we discussed this with a lot of plastics manufacturers, and we basically came up with it's a type of a polymer. We call it Bailey MF because it's obviously commercially sensitive. The company is called Bailey Instruments because the guy who started it is called Tim Bailey. So we did, this is a schematic of the machine, and essentially you've got the load cell at the top, and you've got the the arm that connects to a big column. And basically, that goes down and bends the monofilament. It comes up and it goes down, and it repeats this movement hundreds and hundreds of times. So what we do is we mount the monofilament onto the pedestal there, and that load cell comes down so we can test at what level the pressure is upon the filament when it begins to bend. Okay, so this is where we did a lot of tests on the nylon monofilaments, and this is where we found such a range of grammages. So we determined that a nylon monofilament was not as accurate as it should be. Hence, we moved on to the Bailey MF material. So this thing was testing for days, doing thousands, probably hundreds of thousands of tests on various monofilaments. And what we do as well is, to ensure accuracy, we do testing on the monofilaments that we do already. So when we manufacture them, we take a batch from that manufacturer and we ensure that they're tested so that we can confidently say that we're accurate. So we can say as an organization that all the monofilaments we produce are within 10% accuracy of 10 grams. A paper that was written by Jody Booth and Matthew Young back in 2000, which is a long, long time ago, but they did a test on all of the commercially available monofilaments at the time, and they found that the Bailey monofilament and the Owen Mumford monofilament were the most accurate, and both of those were using this new MF material. So the idea with the monofilament, as Dr. Rogers just said, was the monofilament would exert a 10 gram of pressure against the skin when it begins to bend. Thanks to Euler, he's a mathematician, there's a law of collapsing columns. With the material we use, this monofilament means we will exert the same force against the skin, whether or not you bend the material a lot or only a little bit. As soon as that monofilament begins to bend with the Bailey monofilament, you are exerting 10 grams of pressure against the skin. Okay, if you're in a bad mood one day and you're pushing it firmer against the skin, it doesn't matter, you will only exert 10 grams of pressure against the skin. Because of this, I'm sorry to say that there were a lot of copies made, but unfortunately a lot of the copies involved nylon because it was cheap. They were made overseas, usually in the Far East, and they were given away as freebies, as gifts to clinicians, usually by large pharma and by large wound dressing companies. So we've had to go to them and ask them to, if you're going to give away a diagnostic device, then it needs to be accurate. So this has been our big mantra for over 20 years now, is if you're going to use a monofilament, it should be a 10 gram monofilament. Simple as that. Where to test? I know previous comments. If we look at the International Working Group on a Diabetic Foot, they did a prospective analysis and looked at where the most likely sites are for plantar foot ulceration in a diabetic foot. And these are under the big toe, the first MTP joint, and the fifth MTP joint. Most of the countries that I've worked with usually have 5 sites per foot, so they'll use the third MTP joint and sometimes the fifth toe as well. The reason being that if you imagine the anatomy in the plantar aspect of the foot, you have 3 plantar nerves that supply the forefoot. Usually, the medial plantar nerve will supply the big toe across to sort of halfway across the third toe. Then you have the lateral plantar nerve that will take it from halfway across the third toe towards the outside of the foot, and the sural nerve comes up the lateral side of the foot, so usually supplies the outside of the foot and the lateral half of the fifth toe. So by doing 5 tests, you're covering all 3 plantar dermatomes. That's the argument to do more testing. One of the things we're often asked is, how long does a Bailey monofilament last? Well, the question is, it depends how long you use it. If you cast your mind back to the image of that little testing rig, this is where we get all our data from. Thankfully, it was automatic, so we could program it and it would test overnight. We didn't actually have to sit there and move the arm ourselves, because that would have taken months, if not years. So we show that we can remain accurate to within 10% of 10 grams for around about 15,000 bounces. Okay, so if you are using 5 sites per foot, assuming your patient has 2 feet, then that's 10 sites per patient. So that means that a Bailey monofilament can comfortably be used on 1,500 patients. This works out in terms of cost, because people in healthcare are also concerned about cost. In pounds sterling, it means that every patient that is tested using a monofilament, that test is 1 pence. Okay, so it's a very, very cheap way of testing patients accurately. Now, I've got a short video here. We did a test on Wednesday, I think, earlier this week, so hopefully it'll work. But essentially, when you're testing the patient, from a diabetes point of view, once the patient has been diagnosed, they have a whole plethora of issues to deal with. So they basically get what we call the opathy syndrome, if you like. You're talking to your patient, they've just been told that they suffer with diabetes. That usually comes as a shock. They've now got to be careful about what they eat. Some of them may be taking oral hypoglycemic tablets. They may be on insulin. They've been told that their eyes can be damaged. They may go blind. They've told about kidney damage, nephropathy. They're told about neuropathy, retinopathy. So they've taken a lot of information in. So this is part of the reason why the diabetes patient seems not to listen. It's a big diagnosis. You know, they have a lot to deal with. So repeating the information you have, repeating the education, it may seem boring to us as clinicians, but to the patient you have to reinforce all the time. Okay, and one of the things with monofilaments, if you whip out your monofilaments, you push the button down and reveal a monofilament, a lot of those patients will suddenly think, oh no, not another needle. So you have to warn them what's going to happen. Say, there's a monofilament, we're just going to test if you can feel this. And the best way to do it is if you get them to hold out their arm or their hand and just poke them on their arm or their hand. So they know A is not a needle, another needle, and they know what to expect. Okay. Then you ask them to look away or close their eyes, and you will test the patient, and it's a yes/no test. So you apply the monofilament until it bends to the skin, and before you do that, you ask the patient, just tell me when you feel something. So as a clinician, then you will bend it against the patient's foot, and hopefully they will say yes. Okay, and as Dr. Rogers said before, you can sometimes move towards the foot and not touch it with a monofilament, just in case the patient's peeping. But essentially what you want to do is to understand that at the hallux, at the first MTP joint, and at the fifth MTP joint, whether the patient is sensate. Okay, simple as that. Do not test on callus. Obviously, don't test on a wound. If the patient has a wound or an ulcer, then again, you don't need to use a monofilament because they've already got problems. But if they've got a callus there, even though it's only a sort of a wisp of a callus, or not much, the monofilament does not work on callus. So if you, for example, that picture there, the monofilament is just beginning to be applied underneath the patient's hallux, big toe. So if there's a lump of callus there, what you would do is you'd move the monofilament so you test as close as you can to the site, but not on the callus. Okay, so you'll do both feet, and if you find that the patient hasn't said, yes, I can feel a monofilament on one site, you can go back to that site after you've finished the tests on the rest of the feet and test again. If they still can't feel it, then you can say they've lost protective sensation. Okay, so hopefully this video now will just be very short and sharp, and you'll see that the clinician testing the feet. Okay, that's the test. It's nice and simple. Like I say, the most important thing is that the patient has their eyes closed or is looking out the window. Okay, there's a simple test as well, a trick rather. What you can do with the patients is, if they are a little bit nervous, then if you get them to clasp their hands together, their own hands together, then that gives them something to think about. So they're not waiting to say yes. A lot of patients, when they're in the clinic, they want to say yes to the clinician. So if they think the answer should be yes, they'll say yes. You don't want that in this particular case. What you want them to do is to acknowledge the fact when they can feel that monofilament. Okay, so you should be a little bit careful with patients. So the conclusion is, by identifying that patient with a loss of protective sensation, you are then increasing their risk factor of developing a foot ulcer. And at that point, as has been said before this morning, you need then to begin the education. So simple things like examine their feet once a day, looking inside their shoes, making sure there's no bits of grit, making sure the shoes fit. As has been said before, one of the early indications that patients do suffer with neuropathy is they tie their shoes tighter. Okay. Another thing to look out for with patients with neuropathy as well. Remember, as Paul Brand said, they've lost the gift of pain. If any of you step on something, you'll take your foot off straight away. With a diabetes patient who suffers neuropathy, they won't have that with them any longer. Just to give you a nice illustration to finish with, we had a patient come into the clinic whose presenting complaint was, my ankle clicks, but only in the kitchen. And that was his presenting complaint. So we took both shoes and socks off, and he had a little tack or a drawing pin stuck in his left heel. So his presenting complaint was my ankle clicks, because he couldn't feel the drawing pin. The reason he couldn't feel it throughout the entire house was that this entire house was carpeted, but in the kitchen it was a laminate, like a wooden floor. So that's where the drawing pin clicked on the floor. And that was his presenting complaint. It wasn't, I have a drawing pin in my foot, or I have a tack in my foot. It was, my ankle's clicking. That was the significance of his loss of protective sensation. Okay, so an early indication of this is tingling, or sometimes a burning sensation in the toes. And if the neuropathy worsens, then that spreads back through the foot as if the patient is putting a sock of neuropathy on, if you will. So the idea of the monofilament is it's a warning system to say this patient has lost their protective sensation. They need to look after their feet a little bit more regularly. They need to be under the care of a foot health professional. So in the meantime, they'll be making sure their shoes fit, there's nothing in the shoes. There'll be other things, such as if they're on a beach, they don't want to walk across hot sand, because in many cases they won't be able to feel it, etc. So their eyes and their fingers need to take over from the sensation of their feet. And that's where the monofilament comes in. This determines at what level you educate the patient and at what level they receive a greater amount of care. So there you go. Thank you very much again for your attention. And if you have any questions, my colleague Gemma and myself will do our best to answer them.